I've been offering SLT to my patients since it was approved by the FDA in 2001, and since then we've treated just under 4,500 eyes. I find more treatment to be more effective, and I use 240 degrees between clock hour 2 and clock hour 10 for 8 clock hours. I aim for champagne bubbles and titrate the energy through the treatment. When I start out, I use about 1 to 1.2 for dark irises, 1.2 to 1.4 for green irises, and 1.4 to 1.6 for blue irises. For dark pigmented individuals, I will probably go under 1. For patients with pigmentary glaucoma, we use 0.4 to 0.6. And for exfoliative glaucoma, we will generally use 1.6 to 1.9 millijoules. We generally treat the same way. For narrow angles, we aim to treat the trabecular meshwork without hitting the iris or the ciliary body. I would not use SLT where there is an ongoing inflammation, for example in uveitic glaucoma. I would not use SLT where the angle is completely closed, and I would not use SLT where there's neovascularization of the angle. I find you have to have a healthy working trabecular meshwork upon which you can deliver a shot. It's not critical that the shot be in focus because this is not a collimated beam. I would say patients who are suitable candidates for SLT are patients with primary open-angle glaucoma, pigmentary glaucoma, exfoliative glaucoma, patients where you can visualize the angles. Patients who I should think are not suitable for SLT are patients where the angle is closed, like synechial closure of the anterior chamber angle. Patients where there is an ongoing inflammatory process, either sarcoidosis or tuberculosis or uveitic glaucoma, where the eye is already inflamed. And in patients where there is neovascularization of the angle that we would see after central retinal vein occlusion or diabetic retinopathy with neovascular glaucoma. When I treat patients, what we call secondary treatment, patients who are on medications, what we do is we keep them on the medication and we treat both eyes. I wait 2 months because there are late responders as late as 8 to 12 weeks, and we check the pressure. If a patient is on 4 medications, say, the first medication we'll stop is the prostaglandin because SLT functions as an outflow agent and prostaglandins are an outflow agent. The next medication we stop is the alpha agonist because those usually cause side effects like red eyes, and patients notice those. The next thing we'll stop is dorzolamide, which is an aqueous inhibitor. And the last thing we'll stop is the beta blockers. In each change in medication, we wait 1 month. At 2 months after the second laser, we'll assess the pressure, and then we'll stop the medication in the order of prostaglandin, alpha agonist, carbonic anhydrase inhibitor, and beta blocker, separated in 1 month intervals. I routinely do use non-steroidal anti-inflammatory agents after the SLT. We usually use bromfenac once a day. It is very easy for the patients to use. For an initial treatment, either primary, meaning the patient's not on medication, or secondary, the patient is on medication, we use it for 3 days. For a repeat treatment, we use the non-steroidal anti-inflammatory drops once a day for 5 days. There have been episodes where patients were either intolerant to or allergic to the medication and we didn't use it. I found it did not affect the long-term efficacy of the laser. It was just a bit more uncomfortable for the patient during that time.